So, sir, after 10 seconds, we will live on the attendance platform.
Okay.
So, sir, it's 3, 2, 1. We are live to the attendance platform. Over to you, sir.
So very good evening, one and all, dear ladies and gentlemen, and we thank you all, fellow doctors, for uh, being part of this wonderful session to know further on RNA and its need gaps in heart failure. As you all know, the estimated prevalence of heart failure is up to 4.6 million, with an average 1.8 million hospitalizations occurring annually in India. Also, our population doesn't exactly fare well. We tend to have HF admissions at a much younger age compared to our Caucasian brethren with a much higher mortality rate. So, what are the right practices that we need to involve when we see a patient with heart failure? What are the drugs we need to choose? Uh, are the drugs we give to our patients, are they just for symptomatic benefit, or are we truly escalating and giving the benefit of drugs which give mortality benefits? To know further, let's hear directly from the expert. And today we have none other than Dr. Peeyush Jain himself, as you all know, who needs no introduction in the field of either medicine or cardiology. Nevertheless, I have the honor to introduce sir. So we have today Dr. Peeyush Jain, sir, who is the Director of Non-Invasive Cardiology and Head of the Department of Preventive and Rehabilitative Cardiology at Fortis Escort Heart Institute and Research Center, New Delhi. He's been a guest speaker at CSI in multiple conferences on multiple occasions, is the editor-in-chief of The Heart of the Matter, a bi-monthly journal of heart and diabetes care from 1996 to 2006, a former peer reviewer of the Indian Heart Journal, a member of the editorial board of Cardiology Today, an author of more than 16 books in medicine, and has, to his credit, over 100 articles published in national as well as international peer-reviewed journals. So with the same, I hand over to our esteemed speaker. Over to you, sir.
Thank you. Thank you, Dr. Muralidharan. And it is indeed, again, a unique opportunity for me to be on this forum to discuss the role of ARNI in heart failure. So it's a longish presentation, and I have tried to abbreviate it as much as possible. There were 119 slides. I don't think anybody has the attention span to go through all these 119 slides thoroughly. So what I will do is I will go through the slide, but also talk extempore from time to time to give you an overview of what I understand, what needs to be done in patients with heart failure. So let's start with how do we actually define and stage heart failure? How do we classify its severity? So we all know that heart failure is a clinical syndrome. It's not a disease. It's a clinical syndrome with many causes. So this clinical syndrome may have present or past symptoms or signs caused by a structural or functional cardiac abnormality, and corroborated by at least one of the following, that is elevated natriuretic peptide levels or objective evidence of cardiogenic pulmonary or systemic congestion, which means in cardiological terms we call it high filling pressures. So heart failure actually starts not at the time when the patient is symptomatic with symptoms of breathlessness, swelling, orthopnea, PND, but you actually classify heart failure into 4 stages. And the first stage is when the patient is not in heart failure, but at the risk of getting overt or clinical heart failure. So there may be a patient who has got, hypertension or diabetes, but no structural functional defect in the heart. But then comes the stage B, where the patient does not have current or prior symptoms or signs of heart failure, but has got structural heart disease, abnormal cardiac function, or elevated natriuretic peptide levels or cardiac troponin levels, particularly natriuretic peptide levels. So any patient, say for example, who has got hypertension or diabetes and has got left ventricular hypertrophy without anything else by way of structural or functional defect may be classified as a person who has got stage B heart failure. Whereas stage C heart failure is when the patient starts getting symptoms because of decrease in the cardiac output or high filling pressures. And the leading complaints of heart failure patients, as we all know, is either breathlessness or there is a sense of exertional fatigue caused by low cardiac output, low as compared to what should be the cardiac output to meet the oxygen demands of the tissues. And then, of course, stage D is the advanced heart failure, where the patient has got severe symptoms and signs of heart failure at rest. And this patient is likely to have recurrent hospitalization despite guideline directed medical therapy, GDMT, uh, uh, and the patient may not fully respond. Filling pressures continue to be high despite the diuretic therapy and other therapies. May require advanced therapies like transplantation, mechanical circulatory support, or maybe a end of life care, that means palliative care. So ordinarily we divide heart failure into three categories, rather four categories at the moment, where the patient has got a reduced left ventricular ejection fraction with an LVEF of less than 40%, then heart failure with mildly reduced ejection fraction or mid-range ejection fraction, that is 41 to 49%, then heart failure with preserved ejection fraction, that is heart failure with an LVEF of more than 50%, and then the newer entity of heart failure with improved ejection fraction, where the baseline ejection fraction was less than 40%, but now the ejection fraction has increased by at least 10-point increase from the baseline, and the second measurement is more than 40%. So this is a patient who still has heart failure, but the patient has improved. Okay. So when a patient develops symptoms particularly, then it is likely that the patient will get hospitalized sooner or later. And those who get hospitalized once, they are likely to get hospitalized again and again. And as the number of hospitalizations increase, there is a further increase in the frequency of hospitalization and incomplete response to the drug treatment. And this leads to what is known as the stage D heart failure, or chronic persistent heart failure with high filling pressure, symptoms, a incomplete response to the drug treatment or resistance, and all other problems associated with that, like diuretic resistance, the renal dysfunction, arrhythmias, and many of these patients actually also have sudden cardiac death, either because of the scarring of the heart due to heart failure or the underlying condition, or due to the calcium spikes which lead to early or late after depolarizations. So the two basic pathophysiological factors which are supposed to uh, increase and perpetuate heart failure, one should remember, is the sympathetic overactivity, and second is the RAS activation. So sympathetic nervous system overactivity, that leads to vasoconstriction, increase in heart rate, increase in contractility, giving rise to increase in the myocardial oxygen demand. Also increase the vasopressin, which is basically the antidiuretic hormone, and therefore a tendency for fluid retention. And there is vasoconstriction, giving rise to increase in the systemic vascular resistance. The RAS activation basically also has nearly all the same features: vasoconstriction, increase in the blood pressure, increase in the sympathetic tone, indirectly giving rise to increase in the heart rate. But then there are others, like direct effects of RAS activation in the form of angiotensin 2, and then indirectly through increase in the aldosterone and cortisol, giving rise to left ventricular hypertrophy, left ventricular fibrosis, vasoconstriction, apoptosis, etc., etc. And these two are the targets for treatment. But before I say that these are targets for treatment, one should also remember that these are also mechanisms to overcome the pathophysiological features of early heart failure so that the heart is able to maintain the cardiac output. But when they become chronic and persistent and excessive, that is something that actually perpetuates the heart failure. And how does it perpetuate the heart failure? Particularly the sympathetic overactivity gives rise to the left ventricular remodeling. Now, what is remodeling? By remodeling of the left ventricle, we mean that normally the left ventricle is elliptical in size and it contracts, usefully with a kind of optimal oxygen demand. But when it becomes remodeled, it becomes more and more spherical. And because of the increase in the sphericity of the left ventricle, there is an increase in the myocardial oxygen demand according to the Laplace's law. And therefore, the heart is not able to sustain the contraction because it does not get the enough myocardial energy and oxygen which is required for effective contraction to take place. And in any case, the contraction becomes ineffective because of the sphericity. So to counteract that as a kind of uh, compensatory phenomenon, besides the sympathetic overactivity in RAS, there is also secretion of the natriuretic peptide from the atrial muscle, from the myocardial muscle in response to the myocardial stretch. And it tries to counteract some of these pathophysiological outcomes like increase in blood pressure, vasoconstriction, increase in sympathetic tone, sodium retention, increase in the vasopressin, increase in the aldosterone indirectly through RAS activation, and also it tends to decrease the degree of myocardial fibrosis and hypertrophy in the long run. So this is basically a compensatory mechanism. So here, the secretion of natriuretic peptides like BNP and ANP, they are helpful in counteracting some of the effects due to excessive sympathetic activity and the RAS activation. Okay, so we go further and straight away go on to how to counteract some of these mechanisms and how to enhance the effects of the natriuretic peptides. So you have basically 4 pillars of treatment for heart failure, particularly with reduced ejection fraction. The ERNI, I should say ERNI now, not ACE inhibitor as the first choice, beta blockers, the SGLT2 inhibitors, and the mineralocorticoid receptor antagonists. Now here I may say at the outset that out of these 4, the most effective is the beta blockers. The beta blockers should not be ignored in the scheme of things for heart failure management, particularly in a patient who has got chronic heart failure. So what beta blockers, ERNI, MRA, and maybe SGLT2 inhibitors do is that they cause reverse remodeling, and this is observed in some of the mechanistic study, and we will talk about which mechanistic studies have shown reverse remodeling of the left ventricle with ERNI. But these are the 4 4 pillars of the treatment, the basic treatment. And then of course, in presence of iron deficiency, you need to replace iron, and this iron deficiency actually can be present with or without anemia. Then with functional mitral regurgitation of severe degree, you could try to control it by device therapy or through surgery. Device therapy is nowadays favored but very costly. Those patients who have got atrial fibrillation, which contributes to the aggravation of the heart failure because of the loss of the atrial kick, anticoagulation and the rate control is something that is important. Those patients who are on maximum possible dose of beta blocker but still getting a resting heart rate of more than 70, ivabradine is the drug of choice for reducing. For this purpose, the calcium channel blockers like diltiazem and verapamil are absolutely contraindicated. But of course, the patient has got to be in sinus rhythm. The Patients who continue to be in heart failure and they have got a widening of QRS, particularly left ventral branch block morphology, with a QRS of more than 150 particularly, but maybe even less, more than 130. The cardiac resynchronization therapy with biventricular pacing is something that also helps in patients with intractable heart failure. Now, the recent additions like Vericiguat in patients who had recent worsening of heart failure on GDMT, that is guideline directed medical therapy, but still symptomatic. One could add on to these also. And of course, for terminal patients where a patient has got advanced heart failure, a very costly modality of treatment, that is LVAD in suitable patients, is something that could be helpful. So ICD is prophylactic in reducing the risk of sudden cardiac death when the left ventricular ejection fraction is less than 35%. So if you look at the classical treatments for heart failure like ACE inhibitor, beta blocker, and MRA, you find that there is a reduction in the mortality with ACE inhibitors, reduction in the mortality with beta blockers, also reduction in the mortality in patients with severe heart failure and low ejection fraction with the MRA like spironolactone as shown in the RAISE trial. And this slide actually clearly shows that it is the beta blockers which are most helpful. But still, despite all that, the heart failure mortality continues to be high, and that is why modalities like ERNI and SGLT2 inhibitor were developed. So what does ERNI do basically? ERNI, as I said, is something that inhibits an enzyme which inactivates the natriuretic peptides. So what it does is basically it increases the duration of action of the natriuretic peptides like BNP and ANP, and therefore leads on to a dual mechanism of action where ARB like valsartan is helpful in reducing the RAS activity through angiotensin 2 receptor type 1 inhibition, and then of course through increase in the activity of the natriuretic peptides which are secreted endogenously for a longer period of time. Of course, reducing the sympathetic nervous activity is done by the beta blocker. So it's a dual mechanism. ERNI works two ways, reducing the RAS and increasing the activity of the natriuretic peptides. So ERNI actually may be used in adults, may also be used in pediatric patients with LV systolic dysfunction, and the most of the evidence for the use of ERNI in heart failure pertains to the occurrence of heart failure in adults with low ejection fraction or mid-range ejection fraction. In fact, recent studies have shown that it may be effective in a subset of patients who have an EF of as high as 57%, but not beyond. But compared to the pediatric population, the evidence for adult heart failure is much more. In pediatric patients, the benefit is mostly been demonstrated in terms of improvement in the NT-proBNP, and that indirectly is an indicator that improves the cardiovascular outcomes. So one contraindication for ERNI at its outset should be highlighted, and that is angioedema, which has occurred due to ARB or ACE inhibitor therapy. Secondly, ACE inhibitor and ERNI should not be used concomitantly because it can give rise to angioedema, which may be fatal. So there has to be an interval of 36 hours between ACE inhibitor and the ERNI. The patient who is already on ACE inhibitor, you want to switch over to ERNI because of the persistence of the symptoms of breathlessness or persistence of heart failure. ACE inhibitor washout should be there for about 36 hours. Then, of course, the other concerns with ERNI, and that also includes the concerns with MRAs also is, one is hypotension, second is impairment of renal function, and third is hyperkalemia. Now let us talk about these one by one. So the patients who are a candidate for ERNI are those who are not volume depleted. They are either volume overloaded or they are isovolumic. They are not dehydrated and they don't have hypertension, particularly symptomatic hypertension. So classically, it is said that you should start early when the baseline systolic blood pressure is 100 millimeters of mercury or more. In actual practice, many of the patients who have just recovered from acute decompensated heart failure in the hospital, the systolic blood pressure is less than 100, but they are asymptomatic. So if they don't have postural hypertension and they are not dehydrated, a small dose of ERNI could be started in patients who have got systolic blood pressure as low as 90 millimeters of mercury, but it is a physician's call. And it is expected that this patient will be in close touch with the doctor, because giving a medication which can actually potentially cause hypertension, and you are not able to keep in touch with the patient, uh, you know, uh, on a frequent basis, that's not a good idea. Second is the impairment of renal function. Now, this is something that also needs to be highlighted here for clinical practice. Those who have a baseline normal EGFR that is more than 60 or anything between 30 to 60, if their serum creatinine has been stable and not rising in the past few days or in acute situations in the past 24 hours, one could start early even if the EGFR is less than 60, but not less than 30. That is number one. Secondly, some increase in the renal dysfunction or decrease in the EGFR is expected. So anybody who is started on ERNI, and this actually comment also pertains for MRA also, if as long as their serum creatinine does not increase beyond 0.3 milligram per deciliter over next few days, and secondly, their EGFR does not decrease beyond 25 to 30%, it is not a good idea to stop early. Uh, it should be continued, because actually uh, it is not a sign of intrinsic renal dysfunction. It is only hemodynamic effects of ACE inhibitor, ARBs, and ERNI and MRA also that is responsible for it. But of course, if the patient develops more than 50% increase in the serum creatinine levels, then the dose of ERNI should be reduced by 50%. And if the rise in the serum creatinine is more than 100%, that means it doubles over next few days, then the ERNI has to be stopped. And one should carefully look into all the factors which could additionally give rise to increase in the renal dysfunction, and maybe restart ERNI after a few days or few weeks once the patient is thought to be responsive to ERNI without too much of side effects. The most common cause for a rise in the serum creatinine following ERNI in clinical practice as such is volume depletion. That is the most important, and borderline blood pressure or slightly low blood pressure. But then other alternative reasons should also be sought of, and these could include bilateral renal artery stenosis, intrinsic renal dysfunction about which the doctor does not know. So a patient who shows repeated increase in the serum creatinine following administration of any dose of ACE inhibitor, ARB, or ERNI should be subjected to a renal artery doctor to rule out renal artery stenosis. So much so about the impaired renal function. But then let's talk about hyperkalemia. So the hyperkalemia is also not an uncommon problem with ERNI. And many times you have to either reduce the dose of ERNI or you need to stop ERNI for a while or permanently. And that is a problem, because what to do? Because if you are not able to provide the patient with ERNI on a stable dose, and it is quite possible that the patient will also not be able to tolerate MRA, then what else to give? You can only give beta blocker, you can give SGLT2 inhibitor, that does not affect the serum potassium levels. And then, of course, the loop diuretics. So for such a patient where ERNI and MRA cannot be given at all, The alternative is to start the patient on a combination of isoforward dinitrate and hadlazine in incremental doses. Uh, that is an alternative because it does not cause any hyperkalemia. But then hyperkalemia does not have only ACE inhibitor, ARB, or ERNI as the cause, or MRA as the cause for hyperkalemia. Many of these patients have got additional factors. Now, what are these additional factors which are responsible for the occurrence of hyperkalemia with an increased frequency when a patient is given ERNI? One is the patient is dehydrated, that is number one. Secondly, a patient who is on other potassium retaining drugs, and that includes non-steroidal anti-inflammatory drugs. So that should be kept in mind. Thirdly, the drugs which may have been given for some other reason, uh, like many patients, we find that they may be on some anti-aldosterone drug like amiloride, that is there. Then patients who have diabetes, particularly, they are prone to hyperkalemia. Uh, One not so commonly known reason for contribution to hyperkalemia is the beta blockers. Now, the non-specific beta blockers, that means those who are not beta 1 or beta 2 specific beta blockers, uh, like carvedilol or propranolol. Carvedilol is more likely to be given in patients with heart failure. They may be responsible for the occurrence of hyperkalemia. So there, a change in the beta blocker might be helpful in reducing the proportion of patients who develop dangerous hyperkalemia or hyperkalemia, which is thought to be clinically significant for management. Then, of course, it goes without saying that the patient may be taking a high potassium diet, and that needs to be changed. So, the high potassium diet, most of the people think that the potassium is rich, is a rich component of fruits like juicy fruits and banana, but that is not actually particularly true because there are other dietary factors also. The green leafy vegetable in excess, they also contain a lot of potassium. The tomatoes, they also contain a lot of potassium. The nuts are also very rich in potassium. And then lastly, many patients inadvertently and without their asking their doctor, they also take low sodium salts or different kinds of salts, about which they don't know. In the market, they get senda namak, but I don't know whether it is really senda namak or it is a mixture of sodium and potassium salt. They should be encouraged to take the routine white salt, which is not light like light. There is no label like light or low sodium. These are some of the labels that should be looked into, and conventional salt should be taken. It goes without saying that with any the potassium retaining drug should actually be avoided as far as possible. But a therapeutic dilemma is that you have to give MRA also, particularly in those patients who continue to be symptomatic despite beta blocker and ERNI and SGLT2 inhibitors. Their caution is required, and many times, in fact, you have to withdraw MRA and continue with low dose of ERNI to give the maximum benefit at a minimum of risk. Okay, so to summarize the adverse reaction of ERNI, hypotension, hyperkalemia, and progressive renal dysfunction are three things that need to be kept in mind. Okay, coming on to the clinical studies, and this is a very quick, overview of the studies which have been done in the past 6-7 years. This is a study, the Paradigm HF study, which actually was conducted importantly on patients who had got heart failure with reduced ejection fraction, who were symptomatic despite the standard of care, uh, at least NYHA class 2. Majority of the patients were class 2 or class 3, very few patients in class 4. And the comparator were either enalapril 10 mg twice a day versus sacubitril valsartan, that is Ernie, with incremental doses starting from a low dose going up to a target dose of 200 mg twice a day. So here the primary composite endpoint was death and heart failure hospitalization. And then there were other secondary endpoints like all-cause mortality, etc. So over 27 months of median of 27 months of follow-up, uh, these were the key inclusion and exclusion criteria. They there was about 20% decrease in the composite of cardiovascular death and heart failure hospitalization. And this was primarily derived by a decrease in the heart failure hospitalization. Importantly, only 21 patients needed to be treated with ARNI as compared to enalapril to have a 20% further reduction in the risk of cardiovascular death and heart failure hospitalization. And this benefit was seen very early, within a few months. So, looking at the components, while cardiovascular death was also reduced, there was a reduction in the heart failure hospitalization also of about 20% or so. And as a secondary endpoint, there was also a decrease in the overall mortality by about 20%. So about 16 to 20, 15 to 20% in fact. All of these results were basically highly statistically significant. And if you look at the pattern of the decline in renal function, well, compared to enalapril, the ARNI actually did not lead to a more marked decline in the renal function. Both lead to some renal dysfunction because they basically work through a RAS inhibition only. But the difference in the occurrence of the renal dysfunction was not different between the ARNI and enalapril. And this difference between enalapril and ARNI was irrespective of the age, that is early, elderly versus young, uh, uh, the symptomatic class in the beginning, uh, baseline renal function, presence or absence of diabetes, and then of course those who had more marked reduction in the EF versus less marked reduction in EF, presence or absence of AF, presence or absence of hypertension, or prior use of ACE inhibitor or no use, and prior hospitalization for heart failure or no hospitalization for heart failure. So it was a positive outcome irrespective of so many confounding factors, and interactions were not observed between dichotomous baseline data like EF or anti-proBNP or comorbidities or age and things like that. So overall, you could say that over and above the reduction in the overall mortality, the secondary endpoint in the paradigm trial was almost double that observed with the ACE inhibitor, that is with the enalapril in the SALT trial. The other trial, which actually looked into a slightly different aspect of the benefits of RB, was whether it is safe to start ERNI prior to discharge or soon after discharge in patients who are admitted with acute decompensated heart failure, and compared to the ACE inhibitors, which are commonly actually added as soon as the patient is stable while admitted with heart failure. So here, comparison was basically the same between the ERNI and enalapril. And the outcome here, because it was a short-term trial to look into the feasibility of initiation of ERNI, and secondly, some surrogate marker of improvement in heart failure like decrease in the anti-proBNP through week 4 and 8, and of course its safety and tolerability, as I said. Clinical outcomes, well, exploratory because it was not a statistically robust trial to look into that. For that, you need to have larger number of patients, longer follow-up. So short study with a limited number of patients, of about 900 patients. So this is how randomization was done. And what was found was that if you start any in patient with acute decompensated heart failure, as soon as they are off the vasodilators or inotropic agents, their diuretic dose is stable, they are not volume depleted, and their serum creatinine is not rising. You find that over next 4 to 8 weeks, there is uh, a more marked reduction in the anti-proBNP, indicating that it is feasible and it is also probably beneficial because it does lead to a decrease in the anti-proBNP, which is a prognostic marker for the heart failure patients. And this change of the anti-proBNP from baseline to the minimum was actually observed within 1 week, in fact. So early difference in the response was observed within 1 week, which led to further reduction in the anti-proBNP over next 8 weeks. But as you can see in this chart, the maximum reduction was observed within 1 week. So this benefit actually was observed uh, in patients who had prior heart failure and no prior heart failure, and those who were previously receiving ACE inhibitor or ARB or not receiving that. And mm, there was an open label extension of the Pioneer HF trial, the same trial about which I'm talking about. And it was found that beyond 8 weeks, up to 12 weeks, there was a further 37% reduction in the anti-proBNP, indicating that this improvement in the heart failure status is sustained at least up to 12 months. So this is an exploratory analysis because, as I said, it is not statistically significant, finding which can be called a kind of you know, robust kind of finding because it's not statistically powered there. But even over a short period of 56 days, which means how many weeks? 8 weeks or so, there was about 42% reduction in the risk of serious composite endpoints of death, heart failure, hospitalization, uh, requirement for LVAD and transplant listing. 42% reduction. Now, this is too early to say what will be the long-term effect based on this trial alone, but the findings were consistently in the right direction of improvement in the anti-proBNP, meaning thereby reduction in the severity of heart failure and also the clinical endpoints like death, rehospitalization, and requirement for LVAD and transplant listing. And this benefit was actually observed in all kinds of patients with different subgroups, including different LVEFs, different symptomatic class at randomization, different degrees of rise in the anti-proBNP, different systolic blood pressure as the baseline. So this is a consistent reduction. So it lends to the belief that it is possible that using ERNI starting from the time when the patient becomes stable during hospitalization for acute decompensated heart failure or soon thereafter is going to be beneficial for a broad subset of patients. Now, what is the proof that the ERNI actually leads to uh, a reverse remodeling? Now, this is basically an open label study of heart failure patients with reduced ejection fraction who are receiving sacubitril/valsartan. And there you find that over 12 months, ERNI led to about 9.4% increase in the left ventricular ejection fraction, decrease in the left ventricular end diastolic volume index, indicating decrease in the size of the heart, and then, of course, decrease in the left ventricular end systolic volume index, once again indicating the same thing. So this, all these were statistically significant, and this was associated with an improvement in the quality of life as determined by a validated questionnaire, that is Kansas City Cardiomyopathy Questionnaire. Okay. Now the question is, should we actually conventionally start with 25 milligram or 50 milligram twice a day, and then gradually increases to 100, or you then increase to 200 milligram twice a day, and the interval between the dose increments conventionally has been 2 to 3 weeks. But based on this particular study, titration study, it was found that in suitable cases, we can actually start with 100 milligram twice a day and then switch over to 200 milligram twice a day within 2 weeks. But of course, it will be impossible to do in a patient who has got a baseline blood pressure, systolic blood pressure of 100 systolic. So that is what it is. So overall, if you look at the large number of patients, there is no difference in the treatment success or tolerability between the two regimens, but every patient is different. So one should only venture to start a dose of 100 milligram twice a day when we think that the patient will be able to tolerate it. And such a patient will have a systolic blood pressure which is above 100, maybe above 120, that is possible. Or the other scenario is when the patient is already on ARB. If you want to switch over from ARB to irony, and the dose of valsartan in such a patient had been considerable, you could think in terms of increasing the dose from initiating dose from 50 to 100 milligram at the outset. So there are a few other issues related to ERNI, and one is how to uptitrate and institute the treatments which constitute the guideline-directed medical therapy in patients with heart failure. So any patient who has been admitted with worsening of heart failure, or was admitted, not admitted, but was given intensive treatment with frequent observations in the outpatient, such a patient is a vulnerable patient. And this vulnerability period is for the next 2 to 3 months. And there is always a possibility of either further worsening leading to hospitalization, or hospitalization leading to rehospitalization. So 25% of the patients who are discharged from the hospital, they get rehospitalized in first 30 days after the discharge. And during this period of 2 to 3 months, the mortality is as high as 10%. So the endeavor of the clinicians for a patient who has got recent worsening of heart failure with or without hospitalization is to institute the guideline directed medical therapy rather rapidly as possible. Having said that, it is not possible to do it for two reasons in many cases. One is the patient cannot be seen, or you can't keep in touch with the patient frequently following institution of the guideline directed medical therapies. So, and this is a practical problem because many patients are not so well educated. They don't live in your area. They can't come to you, or you can't keep in touch with them because there is no intelligent communication between the patient and the doctor, because the patient is not so well, educated. But if it is possible, the recent studies actually have shown that if you institute the guideline directed medical therapy within 4 to 6 weeks of the discharge from the hospital, with frequent observations of the patient, taking into care the volume status, the blood pressure, the renal function, the electrolytes, the results are always better as compared to a more conservative approach. So one actually needs to, this is an older study actually, the recent study which is not included in these slides is something that was actually shown and presented only in December 2022 in AHA, subsequently published in NEJM. That shows that early institution is a good idea. And the sequencing of the treatment when you want to start, uh, uh, more aggressively to institute all the four components of the guideline-directed medical therapy, uh, you need to actually look into what benefits most, number one. Secondly, what is most rapidly acting. And for to satisfy these two criteria for a stable patient, adding a beta blocker and SGLT2 inhibitor seems to be a good choice for such a patient. And then this may be followed by early and MRA. Of course, MRA, the dose is rather fixed. For SGLT2, the dose is fixed. But for beta blocker and early, dose titration is required and taking care of the parameters which I talked about. So uh, that is possible. The other way is that you start with all four pillars of guideline directed medical therapy in lower doses and rapidly increase the dose with each subsequent visit of the patient or somebody who can actually communicate with you intelligently over the telephone or through video calls. And that is how one could actually come to a reasonable doses for all four pillars of guideline directed medical therapy with or without the secondary you know issues like the ivabradine and iron therapy, etc., etc. So I think I will rather stop here and take some questions from the participants. So, Dr. Muralidharan, I'm stopping my sharing now,
Sure,
and
sir.
I suggest that you please tell me if there are any questions in the chat box.
Absolutely.
If you want to ask any question, if you,
Absolutely, sir.
yeah,
Absolutely.
yeah.
So, one perspective that we wanted to get from you, which is a common audience question that we're receiving from the audience, is uh, what about patients? So, what are the challenges to escalation of guideline-directed medical therapy? What I understand from some of the questions is diuretics, or rather overusage of loop diuretics, one of the limiting factors in Indian clinical practice, due to which maybe the patient's blood pressure is poor or he's volume depleted and hence GDMT is not uh, becomes a challenge to escalating GDMT up. Is that a challenge at the patients who are referred to you? Not obviously at your end as a cardiologist, but for patients who are referred to you.
Okay. So, in real life practice, overusage of diuretics, loop diuretics, as well as underuse, both are very common. Let me first talk about the overuse. So, when the patient improves and the filling pressures are getting normal, more or less normal, it is conventional to put the patient on very minimal dose of loop diuretic or stop the loop diuretics completely, provided the other guideline directed medical therapies are instituted and the patient is asymptomatic. And that is quite reasonable to my mind. In real life practice, most of the patients with heart failure and reduced ejection fraction and heart failure even with preserved ejection fraction will require a minimal dose of loop diuretic. That is number one. The second is stopping the diuretic, loop diuretic rather early. Now, when does that happen? When a patient has been given some diuretic, particularly in the setting of acute decompensed heart failure, and the patients improve symptomatically, sometimes there is an error of stopping the loop diuretic completely or reducing the doses drastically without having the perspective that the patient is still not on guideline directed medical therapies. So the guidance as to whether we can actually reduce the diuretics drastically is through clinical examination If the patient is getting volume depleted, that is a sign that you should reduce the diuretics drastically, no doubt about it. But on the other hand, if you find the patient is asymptomatic and much more comfortable, there is no orthopnea, no PND, and the swelling has also reduced markedly, you need to actually repeat NT-proBNP, and also you need to repeat an echocardiogram and to see uh, the filling pressures. Now, if the NT-proBNPs are still raised and the inferior vena cava is still, you know, large in size, and there is less than 50% variation with inspiration, or the E to E dash ratio at the level of the mitral valve is still high, then it is not a good idea to reduce diuretics. So that is the second point, that the decrease in diuresis should be more objectively decided rather than just looking at the patient. Mm, these are the 2 points. Then the third point that also is important is many doctors may like to reduce the dose of diuretics when they feel that the renal function is deteriorating. Now, that is not a good choice. If the renal functions are not deteriorating markedly and the patient is making good urine and the patient is clinically improving, diuretics should be continued, because that is what is improving the patient and there will be further improvement. Then, of course, after a day or two, one could always reduce the diuretics, but merely increasing the serum creatinine or decreasing EGFR is not a good reason to reduce diuretics in a patient with acute decompensated heart failure.
Thank you so much, sir. A wonderful, very clinically placed, with very clear guidances. Wonderful, sir. Thank you so much. So the second question that has come is, you also mentioned very wonderfully about the role of RNA in a very select patient population with HFpEF up to an ejection fraction of 57. And sir, the question here is that some of our viewers who have actually gone through the Paragon HF trial, maybe superficially, they did find that the Paragon HF trial had actually failed for RNA. But as you rightfully put forth, the subgroup of patients with an EF of 57 did show some improvement, and there was a subsequent update in the ACC guidelines too. So the audience wants to know your views. So where exactly in HFpEF patients and how to place RNA?
See, actually, the confusion has arisen because of the perception that heart failure is associated with reduced EF. That is what we used to think. But now we know that heart failure is just a second. Give me a second.
Sir.
So actually, heart failure is basically a continuum irrespective of the EF. As far as EF is concerned, up to an EF of something like 60%, most of the treatments for heart failure will work, whether EF is 35% or it is 45% or it is 50% or maybe 55%. Beta blockers may be an exception there, but if you look at ME, look at SGLT2, even MRAs, they all work up to an EF of something like 55 to 57%. And merely a negative outcome in the patient who is a male and who has got an EF which is classified as heart failure with preserved ejection fraction does not mean that it is not going to be effective, because heart failure pathophysiology is basically the same. Actually, it's a continuum. I mean, a patient who has got an ejection fraction of something like 41 to 49%, more or less like EF of less than 40% actually, but these boundaries are artificial. Okay, so maybe up to a reasonable EF of 55%, Ernie can also be used, and particularly in female patients and those who have got an EF of up to 57%. In fact, based on the data with this trial, the American guidelines actually have they have recommended that it could be used, though it's not a class 1 indication. For European guidelines, they have still not talked about it and they have not approved of it. But that is what happens. You need more trials with Ernie in patients with heart failure with preserved ejection fraction.
So,
Yeah.
So the last and final question for the day. So titration strategies in heart failure, which drug to use first, which drug to use second, and an interesting question that has come up since you mentioned hyperkalemia and renal function. So what clinical tips would you want to give to the audience when a doctor has to start ARNI as well as spironolactone? Should there be a gap in starting both, or should they be started together at micro doses? How, when, what, where? Your takeaways, sir.
So all kinds of case-based scenarios could be there. Let's talk about patient with chronic heart failure, not somebody who has been admitted recently with acute decompensed heart failure. Now, in this patient, there is no urgency to institute the treatments which are going to be effective immediately. You can start with a beta blocker, you can start with the Ernie, right? And then you could start with SGLT2, and if the patient remains symptomatic despite all these three treatments, then you could add MRA. Of course, you may have to stop at any time, when you have up titrated the dose of Ernie to a maximum, you find hyperkalemia, you have to down titrate that. In that case, MRA may not be possible to give, and you may have be satisfied with beta blocker with maximum tolerated dose of Ernie along with SGLT2 for which the dose is fixed. There are the other extreme, the patient will require all four, but the sequence will remain the same. So this is what it is. For a patient who has got acute decompensed heart failure, who does not have evidence of acute kidney injury during the hospitalization, his kidney function is stable, or his kidney function is stable now, there is no hyperkalemia. This patient is likely to have a recurrence of heart failure if the treatment with all four pillars is not instituted within the next 4 to 6 weeks. And you need to start with the agents which are going to be most beneficial. So as I said, start with the low dose of beta blocker along with SGLT2, and soon thereafter, within 4 to 6 days, you start with low dose of Ernie, and MRA could be added later on, because the agents which are most effective and most rapidly acting should be given first in this situation. But effectively, you have to give all four for such a patient, unless there is some contraindication like intractable hypertension or increasing degree of renal dysfunction, more commonly hyperkalemia. Hyperkalemia is the limiting factor in most cases, in fact.
Thank you so much, sir, for enlightening all of us with those clinical pearls and clinical tips. So we have reached the end of our Q&A, and we would, with your permission, love to give you the vote of thanks.
So nice. Thank you.
Sir, it has been an honest pleasure and an august pleasure to have hosted you. We are very sure that the audience who has attended this webinar, and they have quite keenly, which in this day and era is actually rare in the day and era of the virtual world. So we are very sure that the audience has benefited from the clinical tips and pearls that you have given them, and it has enriched them so that they can improve their clinical practice and patient outcomes. Dear audience, we thank each and every one of you who has actually joined to participate in this academic session. And we are very sure that this session would ultimately enrich your knowledge and experience too. Last and not the least, we also thank our technology partners Imagica Health for aiding in the very smooth streaming of this webinar. Thank you,
So
sir.
nice. Thank you very
Great.
much. Have a nice day,
Thank you,
everybody.
sir.
Prajapati, thank you.
Thank you, sir.
Thank you so much, sir.
Thank you.
Thank you, sir. So with your permission, shall I close this meeting, sir?
Yes, yes, Mr. Peg.
Right.
Thank you, sir. From here now, I'm ending this meeting. Have a great evening to all.
Thank you. Thank you so much.
Thank you.